My name is Jason Schuster. I'm a doctor of physical therapy. Before that, I was a fly fishing guide in Patagonia, Chile for a decade. Now I own a continuing education company teaching other doctors how to do a couple things, including dry needling. This is a part of my online dry needling class, Online Dry Needling 1, Dry Needling in the Autonomic Nervous System. This is about how to specifically target the autonomic nervous system with dry needling. This is a great course, you guys. You can check it out on our website, intricateartseminars.com. The very bottom black dot, the TCC, that's the trigeminal cervical complex, and the bottom black dot is the trigeminal cervical nucleus. That should be right around C2 in the dorsal horn of the spinal cord. And then the trigeminal nerve primarily controls this system, or is a major controller of this system in the brain, you guys. So the two parts of this system that I talk about there's a bunch of them. The two main ones in the trigeminal cervical complex are the LC and the periaqueductal gray. Those ones are less remembered from school for most people. Most people remember what the thalamus and hypothalamus do, right? Very, very important for like hormone production, regulates a whole bunch of other stuff, you guys. Same kind of thing goes for the locus coeruleus and the PAG. They're just not remembered as well as because the thalamus and the hypothalamus are just bigger things. The locus coeruleus is the primary epinephrine producer in our brain that we've discovered so far. So if the trigeminal cervical complex is pissed, if the trigeminal nerve is pissed, or if C1, C2 joint is deviated, that's going to aggravate that trigeminal cervical nucleus. That's going to aggravate the whole trigeminal cervical complex. And it's going to start stimulating the locus coeruleus to pump out too much epinephrine. Epinephrine is a precursor for a handful of pain amplifiers, you guys. It's a molecular precursor. So if you have too much epinephrine floating around your body, and our body and brain can't gobble it up or break it down or change it for when we go to sleep like it should be, if you have a consistent elevated level of free-floating epinephrine all over the place, a lot of that is going to get molecularly altered into different stuff. And one of the first steps that it changes into a lot of the time are some of the pain amplifiers. So the locus coeruleus is a big problem that causes anxiety, depression, tons of mental health problems when you have chronically elevated levels of epinephrine. It's a sympathetic neuromodulator. It elevates the sympathetic nervous system. And then that, in conjunction with the PAG getting pissed off, you guys, the periaqueductal gray, that's one of the biggest sensory processing information centers in our brain. It plays a huge role in our pain perception pathway. So not only with the trigeminal cervical complex getting pissed, do we have the locus coeruleus sending off too much epinephrine, which is a sympathetic neurotransmitter. Then we have the PAG, the periaqueductal gray, which is responsible for interpreting a lot of pain signals. That's also getting pissed off. So you're negatively affecting pain pathways from a bunch of different directions, which is bad for overall health and homeostasis. And then again, we talked about the hypothalamus, the thalamus, hugely important for mental health, physical health, hormone modulation, neuromodulator, concentrations, all that stuff. So that's a pretty good simple picture of the trigeminal cervical complex, you guys. Same thing with the trigeminal nerve. Now, like I mentioned before, you guys, this is a great place also to treat for any type of palsies that people have. So if people have flaccid, droopy muscles, like post-surgery or palsy or anything like that, that is a time that I do think about using different frequencies of stim. However, with the palsies, you guys, the underlying cause of the vast majority of palsies, again, is sympathetic nervous system hyperactivity. I've seen this a ton in my career. I assume lots of people have seen this. It's all over the literature. When people go through just super mentally stressful parts of their life, lots of people get palsies. I've seen it happen a million times to people. Like something's happening with a child, or you go through a bad thing at work, or just life is just tough for a while, and then people end up with like these weird physical conditions, and palsies is one of them. So even though in a palsy the muscles are droopy a lot of the time, the sympathetic nervous system is still the underlying reason that the problem is there. It's just that the sympathetic nervous system has gone so haywire that it's actually like been shut off more or less. So There's lots of studies looking at different frequencies for palsies, for muscular retraining, and most of the literature shows positive effects from electricity going through tissues in general. So I still typically stick to the 1 hertz of frequency, guys. I like it the best because I always think about it. I always make my brain go back to, okay, what is my underlying singular goal of treatment? And that is to regulate my patient's nervous system as much as I can, their autonomic nervous system. Since it's the case that all of our patients' nervous systems are in sympathetic hyperactivity, it makes sense to do the things that causes the most sympathetic depression and parasympathetic elevation. And per my 10 years of clinical experience, which goes with what the literature says, you guys, it says the literature says that low frequency stim is the most relaxing to the nervous system. It's why they use it in EMDR psychotherapy. It's why it's used in a bunch of different things. If you look at the electrical vagus nerve stimulators, most of those are very, very low frequency, even below 1 hertz. So that's how I use it. There's zero wrong with using other types of stim at all. Like I mentioned, the otic ganglion, one of the ganglion of the trigeminal nerve, very, very capable piece of tissue that's able to produce and release CGRP, which helps vasodilate the whole body, guys. So I've gotten rid of people's rashes in their hands and their feet, you guys, by needling the face only. And my initial assumption by trying that the first time I tried it was the CGRP. It was like, okay, if this person has like a skin problem there, part of the problem is that when the sympathetic nervous system goes up, it's a really strong skin vasoconstrictor. That's why your skin gets cool sometimes right when you start needling, and then it'll get hot after it goes parasympathetic. It happens in the hands a lot. So if all that stuff is vasoconstricted, secondary to sympathetic hyperactivity, even though you're needling in the face and you have a problem elsewhere, nothing just stays where you put it in the body, you guys, right? So you needle the face, CGRP gets released, blood flows throughout our body. It doesn't just go to the face, right? So it goes throughout the whole body, and that helps vasodilate the whole body. So the 3 branches of the trigeminal nerve, and this is not super important stuff to know, but it's just good to be aware of, you guys. So the V1, if you look at it in books, this is typically how they label them. The ophthalmic nerve, sensory only. Maxillary nerve, V2, sensory only. So I said there was a couple sensory ones and a mixed one. And then the mandibular branch, the branch that we will be needling here primarily, is mixed motor and sensory, right? So if you look at the very specific neurophysiology literature, they don't talk about the actual trigeminal nerve in the face itself as being all that parasympathetic dominant, but because the big trunk of the trigeminal nerve on the brain side controls all of those areas in our brain so heavily, the brain side of the trigeminal nerve is extremely parasympathetic oriented, and the face side's not quite as much. But just the same with all other needling, you guys. I think the proper way to think about it is we're simply using the tissues in the body as a means of access to the brain. Right? So we are touching pathology in the body so we can change the brain, so then the brain responds and changes the pathology. We are physically doing very little to the actual pathology. What we're doing with the needling, if you understand how to do it, is we are inducing or starting a cascade of positive neurophysiologic change in both the brain and the body, and then they work with each other to improve upon each other. It's just like when mental health gets worse, physical health gets worse. When one gets better, the other gets better, because they have to talk to each other on both sides of the equation, you guys. One of the other really neat things about the face and the jaw is it's very, very closely linked to the pelvic floor. We'll talk about this in our online dry needling for men's and women's pelvic health class, you guys. There's a 10 CEU class. It's all about men's and women's pelvic health. We talk about how to use the pelvic floor to treat other conditions, how to treat pelvic health conditions, all that stuff. But if you look at embryological studies, when the sperm and the egg meet, right, and then the little baby starts forming in the mom's belly, the first little holes that we can see on imaging are the nostrils, the mouth, the urethra, and the rectum. And they're like literally right on top of each other. And then as the human starts to grow, the butt goes down this way and the head goes down this way and all that stuff happens, right? But there's some different connection that we do not understand between there's many connections that we don't understand, that we don't know exist at all. But there's strong indications that there are like serious things that are going on that we just really don't understand. We're going to talk about a little bit about that in a second, you guys. In a little bit, I have a good PowerPoint slide on a little bit of quantum physics stuff, which I think this actually does have a very close relation to, and that's being studied in the literature right now. But so we do know that our pluripotent stem cells, they primarily come from that stage of life, endoderm, ectoderm, and mesoderm, when we're first conceived. And then those are the pluripotent stem cells that can differentiate into all the rest of our body. If there is some connection between sclerotomal type cells, you guys, or certain types of stem cells that are throughout the body, it does seem to be like when you needle the jaw, you get just the weirdest, positive, crazy, very, very fast results sometimes on the pelvic floor and vice versa. And when you add them in together, they both work better. So that makes sense to me mechanically. It makes sense to me as far as we understand the nervous system right now. The two most parasympathetic dominant groups of muscles that we have in the body are our pelvic floor muscles and our jaw and upper cervical muscles, you guys. So that makes sense. They're both parasympathetic dominant. It makes sense mechanically, like if you aggravate the pelvis and you posteriorly rotate the pelvis, that's going to tighten the lat, that's going to pull on the arm. You're not going to be able to elevate your arm as much. That's going to change your neck angle of your muscles. That's going to change your jaw opening angles. That's going to aggravate your jaw. It's easy to make mechanical sense of. It's easy to make neurologic sense of as far as the parasympathetic similarities. However, there's something else. There's some other very strong connection between those two areas that nothing, at least that I understand in science, makes that make sense. So I think there's something outside of our understanding, like there is with everything. Most of the stuff that we talk about, most of it's outside our understanding. But this one seems to be a much more like obvious cause and effect sometimes when you do it. So we'll talk about that a little bit. And then remember, you guys, the vagus nerve, the trigeminal nerve, the glossopharyngeal nerve, and the facial nerve are often talked about as being, parasympathetically oriented. So is the sacral plexus, S2 to S4. So like I mentioned, that's another similarity. Just like with vagus nerve stimulation, especially if you do trigeminal nerve stimulation with low frequency stim, 1 to 5 hertz, you get up to 4 times the amount of beta endorphin release. So most of our patients require some type of pain relief. That helps with that. Beta endorphin depresses chronic sympathetic hyperactivity, which is good. Beta endorphin is released by white blood cells, so endogenous opioids are good for a whole bunch of other stuff. Trigeminal nerve stimulation regulates levels of things like glutamate and cortisol. Those are two stimulating molecules that elevate the sympathetic nervous system and are linked to elevation of the sympathetic nervous system. So not only do they make the sympathetic nervous system go up more, but the sympathetic nervous system produces those molecules and then it acts back on the sympathetic nervous system. So it's very, very interesting. And it leads to all sorts of other bad stuff. So just vagus nerve stimulation, trigeminal nerve stimulation, you guys can be thought of very, very similarly. They're great for things like CRPS, fibromyalgia, post-shingles neuropathy, all that stuff. And the overall result of implementing vagus nerve stimulation and trigeminal nerve stimulation, if you add it into your other treatments, is just the overall way to think about it is you get more autonomic nervous system homeostasis each time you treat your patient. If you add in the parasympathetic treatments that we've spoken about in this class, and especially if you do it in the order that I talk about, you guys, needle the parasympathetic stuff first and then the sympathetic stuff, that really, really helps make treatment more comfortable for the patient. They can tolerate more needles, and it just changes the nervous system more in the proper direction. Thanks for watching, you guys. To continue this video, make sure to keep an eye on my channel. There'll be many parts to this series. This is part of our online dry needling 1 course. We have 2 online dry needling courses. We have a live online dry needling course. and we have a bunch of in-person dry needling courses, all board certified and accredited. If you want a discount on our online dry needling courses, check out our school community. It's school.com/CEU, SKOOL.com/CEU. You can get a discount there on our online dry needling courses, on our online nutrition courses, and a whole bunch of other good stuff. I have weekly Zoom meetings there. We have a private community chat room. It's a really awesome community. Check it out. Thanks for watching, guys. See you next week.